Yes, guys. So we are online. Madam is also here joining. Okay.
Hello, welcome, ma'am.
Hi, Chaitra.
No, ma'am. This side, no Chatra. This time says Kangan, our new
Okay.
intern.
Okay. Hello, Dr. Ajit.
Hello, ma'am. How are you? Good evening.
Good evening. I'm good. Just a minute. I'm trying to share my video.
Okay.
Just a second. Just a second. I'll just change that 1 second.
Yeah, sure, ma'am.
I think that background was for something else. Yeah, that's it. So how are you?
I'm good, ma'am. How are you? Thank you very
All
much, first of all.
No, my pleasure. It's just a very busy time, and I miss this. I miss all this, but I just can't help it.
Yeah, ma'am. I can understand. Yes, your busy schedule and all everything. Yeah.
Very tough. And yesterday, our students have arrived on campus for the face-to-face classes now.
Oh, so
So
when we are starting, ma'am? When you are starting classes and all?
we started today in the hybrid mode.
Okay.
So in the master's program, like this time, I have 64 of them,
Okay.
out of which 57 are here physically, and the remaining are attending online. So we are doing hybrid classes. So
Okay.
all these technology things are a little challenging for us.
Yeah.
Yeah, but it's happening. It's all right. It's okay. We figured it out slowly.
Yes, ma'am. Nice to see you again, actually, in our platform.
Thank you so much. Same here. How have you been?
It was fine, ma'am. We are going very fine.
Hmm. Any new projects?
Yeah, ma'am. Many are going on. Many. Now we are coming up with this vaccine safety. So we are
Mm-hmm.
launching our own vaccine safety week, where we are, calling the our vaccine manufacturers, this from Bharat Biotech and from
Oh, fantastic.
yeah, from Serum Institute of India. Both the directors from both the industry are coming on one platform for for a conference kind of thing. So
Very good.
yeah.
Because among our colleagues and friends, those who have taken the first dose till now,
Hmm.
except for some mild pain at the site, there has not been any side effect.
Yes, 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 yes. So we thought to call both of them, like from Serum Institute of India and Bharat Biotech. So both are coming on our platform to talk to
Great,
people.
great. Good.
Yeah.
Very good. I'm sorry, Kangan. I thought you are Chaitra.
No, ma'am.
That's
Chaitra
completely
is
okay.
not here this time. I think she got busy somewhere.
Mm-hmm.
Yeah.
Yeah, I haven't been in touch with her for some time now. Okay,
Kangan, shall
great.
we
So,
start then?
yes, please.
Yeah, sure, sir.
Yeah, we have around 50 people on our YouTube also, so they're joining slowly. We are
Great,
sending.
great. Yes.
Yeah.
So, should I start?
Yeah, sure. If ma'am permits, you can.
Yes, please. And only thing is, what I'll do is once I start the presentation, I'll put off my video.
Oh, no problem, ma'am. No
because
problem.
the internet is not very good here at the point.
No worries, ma'am. No worries. It's fine.
Please go ahead. Please start.
Yes, ma'am. Thank you. Hello, good evening, everyone. I'm your host for the day, Kangan Ghadiali. Welcome you all to the exclusive webinar on the topic Importance of Folic Acid in Daily Life, a small initiative by CliWare Public Health Awareness Series under Climate Research Solutions. CliWare Public Health Awareness Series is an initiative under Climate Research Solutions that presents to you 365 days of learning. The concept is to bring an educational hub where we create awareness in different forms like webinars, podcasts, and competitions, which act as the one stop solution to clear all myths and queries regarding various healthcare related careers. A platform open to all for C curative, L limited, I informative public health awareness series learning throughout the year. Now, I would quickly start with the session. It seems that you all have joined us and very excited about it. I would now like to introduce the speaker for the day, Dr. Meenakshi Garg ma'am. Dr. Meenakshi Garg ma'am is the coordinator of Department of Dietetics and Applied Nutrition at the Welcome Group Graduate School of Hotel Administration, MAHE, Manipal. She started her professional career as a visiting faculty there and now working there as a nutritionist with the Manipal Group for more than
किसने नहीं पी इपरा हम था किसी ने भी नहीं पी पियो पी लो नहीं तो पहले मामू को चाय पीने दो हमने सोडे पी
I would request everyone to mute their mics, please. Thank you. Thank you so much, sir. And now she's working there as a nutritionist with Manipal Group for more than 26 years now. She has completed her PhD in nutritional sciences in 2019 and her master's in food and nutrition in 1988. She has worked as an assistant professor and taught nutrition to MBBS students at the Manipal College of Medical Sciences in Pokhara, Nepal for 10 years. Returned to Manipal in 2004 and helped commence the PG Diploma in Dietetics course at WGSHA. She was instrumental in starting the MSc Dietetics and Applied Nutrition program in WGSHA MAHE in 2010. She has to her credit 11 research publications in national, international indexed journals, poster and paper presentations, conducted workshops in nutrition, research and health education, guided over 90 postgraduate research projects. She is a PhD co-guide, paper reviewer for elsewhere journals, and also a collaborator in interdisciplinary funded research projects. She has a passion for community nutrition, dual burden of malnutrition, and nutrition transition related outreach and research activities. She is a firm believer in lifelong learning and had recently completed 2 years of international fellowship in interprofessional education and practices from the MAHEFAIMER International Institute for Leadership in Interprofessional Education in October 2020. We heartily welcome you, ma'am.
Thank you so much, Kanak. And for those of you who are unfamiliar, I'm sorry for the short forms. WGSHA is the Welcome Group Graduate School of Hotel Administration.
Yes,
And
Vaksha.
MAHE Mahe is the Manipal Academy of Higher Education. So that is my affiliation,
Yes, yes.
the institute to where I belong. And I'm very glad for this opportunity that our HOI always encourages us to keep taking part in these events.
Your voice
and,
is breaking, Kangan.
Can you hear me now? Is the audio okay, Dr. Ajit?
Yes, ma'am. Your video is okay. I think Kangan's video is breaking.
Okay.
Just a second, sir. I'll check with it.
Yeah.
Okay, shall I try to share screen? Can we continue?
Uh,
1 second.
Hello, sir.
Yes, Kangan.
Am I
Kangan, no
audible?
problem. You please switch off your video. It's okay.
I think there is a lag because of the internet, maybe.
Yes. Kangan, switch off your video. It's okay. And then you can speak.
So should I
Yeah,
introduce
she
her
finished introducing actually.
again? Yes, sir.
Yeah, now you can, yeah.
Shall
So,
I share
ma'am,
screen?
Yes, ma'am,
we
you can
heartily
say.
welcome you, ma'am, and you can share.
Yes. Thanks. Thank you so much, Kangan. I'll try to share my screen now. Is my screen visible?
Yes, ma'am, it is.
Yes, ma'am.
All right. So now I am not able to see anybody. So if there is any lag or anything, if you're not able to see, please somebody just unmute and let me know.
Sure, ma'am, sure. Yeah. All right.
I hope the audio is clear.
Yes.
So once again, thank you for the opportunity, and I would the next maybe 45 minutes, 50 minutes, I would take you over the topic that has been given to me. I know last week was the folic acid awareness week, and I'm sorry I could not take this session last week. But anyways, I guess it's never too late for something good. So importance of folic acid in daily life is what we will cover today. This will be my session outline. I will briefly start by giving the vitamins classification to understand where folate fits in that scene. Then we'll talk a little bit about the overview of folate and its use by the body and its functions, and how the deficiency manifestations of folic acid can have different impacts at different times in the life cycle and for different individuals. And towards the end, I will also talk a little bit about some of the prevalences and incidences of the major deficiencies that can happen because of a folic acid deficiency. And last, we'll talk about what are the recommendations for folate through diet. Also important to understand when we give a recommendation, what is the bioavailability, because the recommendation depends on that as to how much of what we are consuming is available to the body and we are able to utilize. And last, of course, which is very important, is the sources of folate from the regular food that we consume on a daily basis. So starting first with the excuse me, classification of vitamins. This is something very basic, and I'm sure all of you would know this, is dividing them into the fat soluble and the water soluble vitamins. Fat soluble vitamins A, D, E, and K, and water soluble vitamins, vitamin C, and the B group of vitamins. In the B group of vitamins, vitamin B9, folate or folic acid or folacin as we call it, is one of the B group vitamins. So although today we are going to be talking about folate because it is a very important B group vitamin, and you will see now what are the implications that serious implications that can happen if you don't consume it enough in your daily diet. But at the same time, having said that, I would also like to say that please remember that usually when there is a deficiency of one micronutrient, it is always accompanied by one more or two more or three more, because the dietary sources from which one nutrient comes are also sources of other nutrients. So if somebody has entire food groups missing from their diet, or they are consuming them in lesser than recommended amounts, the deficiency, as you probe, you'll realize that it is more than one nutrient deficiency that you are dealing with. But at specific times in the life cycle, folate becomes a very important nutrient, both if it is missing and both if we supplement it. How it is going to help is what we will see over the next few slides. So coming back to the overview of folate. And as you saw there in the previous slide, it is one of the water-soluble B complex vitamins, and it is a natural form of vitamin B9, which is present in food. And it's what we say as folic acid. That is the synthetic form that will be found either in the fortified foods or in the supplements that we buy, is the folic acid. Now, another thing that you may be knowing, the term folate comes from a Latin word called as folium. Also, we say foliage. Foliage literally means green leaves or leaves. And that is why it is easy for us to remember. If we remember the origin, we will know that most of the green leafy vegetables are very good sources of folic acid. And that's the reason the name was given, folium, from where it originated, to call it as folate. And it's not about any specific green leafy vegetables. Almost all green leafy vegetables are very good sources of folate. So it is not dependent on a particular specific green leafy vegetable, which is expensive or non-expensive. Anything which is in season, and always we say when it comes to the concentration of micronutrients in green leafy vegetables, the darker the color of the green leafy vegetables, the better will be the concentration of micronutrients. So all our local greens that are seasonally available will provide a good amount of folate. So also known as folacin, folic acid, it has a chemical name that sounds something like a dinosaur. Pteroyl glutamic acid, or it's easier to say PGA for short. For me, that is like a tongue twister there. So the primary biochemical function of folate, this is where we have to understand, and that is when you will be able to understand the importance and the deficiencies that will manifest as a result of that. So folate is important to transfer single carbon units required in the biosynthetic reactions of nucleic acids and amino acids. So this is something that is important throughout the life cycle, but more so during the periods of growth, the requirement is even higher. The primary coenzyme form, that is the tetrahydrofolate, serves as part of an enzyme complex that helps to transfer the one carbon compounds that arise during the process of metabolism. So what does this do? This action helps to convert vitamin B12 to one of its coenzyme forms, synthesizes the DNA required for all rapidly growing cells, and regenerates the amino acid methionine from homocysteine. So that is one of the major things that we have to remember and keep in mind as we move along. Now, an adequate folate supply is required, therefore, for rapidly growing and multiplying cells in our body. And that is why I said more important, the requirements to meet are during the period of growth, but also other times in life, folate requirement is something that we need to meet on a daily basis. Now, along with vitamin B12, folate is essential for the synthesis of the nucleic acids. Other functions include methylation of DNA also as a part of the epigenetic regulation. It also ensures supply of methionine for the synthesis of various proteins. The synthetic form of folate, pardon me, is folic acid, used in supplements and also in the fortified foods that are available. After supplementation, folic acid is absorbed unchanged and reduced to the dihydro and the tetrahydro forms in cells in the post-absorptive phase. One second. So to understand that very briefly, I'm not going into very much details as far as the biochemistry is concerned, but just a little bit for us to understand the functioning, the absorption and activation of folic acid is important for us to understand. So in the fortified foods and supplements, like we said, in the form of folic acid, it is present in a monoglutamate form containing only one glutamate, whereas in the naturally occurring folate that we find in foods occurs in a polyglutamate form. Mostly it contains about 6 glutamates. So here one example is there with spinach. It could be any green leafy vegetables, but so what happens now after the consumption, whether you are consuming it in the form of a polyglutamate or a monoglutamate, finally, we have to understand the process of the absorption and how the body is going to utilize and activate the folate so that the utilization can really happen. So during digestions, we have enzymes on the intestinal cell walls, which will hydrolyze the polyglutamate to monoglutamate and several single glutamates. So here you can see in the intestine, digestion breaks the glutamates off and it adds a methyl group. Folate is then absorbed and delivered to the cells. The monoglutamate, after attaching to the methyl group, is then inactivated for storage in the liver and other body cells. Now, once this is trapped here, it's in an inactive form in the cell. In order to activate the folate, the methyl group must be removed by an enzyme that requires the help of vitamin B12. That is why, if you remember, we said along with vitamin B12, folate is going to help in the synthesis of the DNA. So now, without that help, folate remains trapped in its methyl form, unavailable to support DNA synthesis and cell growth. So what is happening here is, to activate the folate, vitamin B12 removes and keeps the methyl group, because after the attachment with the methyl group, the folate became inactive and it got stored in the cell. Now, this is going to help to activate the vitamin B12 also. So both the folate coenzyme and the vitamin B12 coenzyme are now active and they are available for DNA synthesis. So it is very important that the presence of the B12 is a must in order for that activation to take place. So once that activation happens, then the availability is there for the DNA synthesis and other functions to happen. So very broadly, it helps in the synthesis of DNA, as we said, also helps in the production of the red blood cells. So the requirement is throughout life. Also helps with, works with B12 and vitamin C to help the body to digest and utilize the proteins for various cells that we require. So what will happen if there is a folate deficiency? What are the things that could go wrong? Now, folate deficiency, now, like we said, is needed for cell multiplication. So if there is a deficiency, it will impair cell division. Also, it is going to impair the protein synthesis, processes that are critical to the growing tissue. So both those functions are going to be hampered. So in a folate deficiency, the replacement of red blood cells and GI tract cells is going to falter. Not surprisingly then, two of the first symptoms of a folate deficiency are anemia and a GI tract deterioration. Now, when GI tract deterioration happens, because there is a deficiency of folate inherently present, it is not only going to hamper the folate utilization by the body because the deficiency is there, but it is also going to lead to malabsorption of other nutrients as well. So when there is a damage to the GI tract, it will lead to poor utilization of other nutrients as well. And this is something that we see very common among alcoholics because the absorption gets hampered and the malabsorption then results in multiple micronutrient deficiencies. The anemia of folate deficiency is what we call as macrocytic or megaloblastic anemia, and it is characterized by large immature red blood cells. So megaloblastic anemia is when we say that the young RBCs have failed to mature. And macrocytic anemia, the RBCs are large, as you understand by the term macro, but they are few and less in number, and also they have less hemoglobin than normal. So sometimes we usually, you must know that we say that a low hemoglobin level is usually an indicator of a poor nutritional status overall. And sometimes when we are not able to identify the exact cause and we keep treating, thinking that it is only iron deficiency, we are only going to aggravate the problem for that individual. So without folate, DNA damage interferes with the synthesis of the red blood cells as they attempt to divide and mature. So resultantly, there are fewer but larger RBCs. And if that happens, they are not able to carry oxygen or travel through the capillaries as efficiently as the normal RBC. So that is something that is going to happen as a repercussion in a folate deficiency. Some of the accompanied symptoms in folate deficiency are also glossitis and chelosis. Now, glossitis is infection and inflammation of the mouth, and chelosis is infection and inflammation of the lips. So this is something that, glossitis is infection and inflammation of the tongue, and chelosis is infection and inflammation of the lips. So a lot of these, and this is accompanied along with riboflavin deficiency also. So like I said, it will not just be a single micronutrient deficiency, it will usually be accompanied by other micronutrient deficiencies as well. So this is what we were talking about. This is what is going to happen. Here you can see the normal blood cells and macrocytic anemia is what you can see a comparison. So in normal RBC production, you can see the DNA synthesis and cell division will begin. Hemoglobin synthesis will begin. Hemoglobin synthesis intensifies. slowing the DNA synthesis and cell division. The nucleus migrates closer to the cell wall. Then the nucleus and all the cell organelles will leave the cell, and you have mature RBCs, which are small, disc-shaped, crescent shape, as you know, the disc-shaped RBCs containing only cytoplasm packed with the hemoglobin. Now, what happens in a vitamin B12 or a folate deficiency? Without folate, the DNA strands will break and the cell division is going to diminish. RNA synthesis, however, will continue. So because of that, that will lead to a result in a large cell with a large nucleus. And these RBCs are now relatively large. We call them macrocytic because of that. They're also irregularly shaped and often, but they have a nucleus, but they cannot carry oxygen or travel through the capillaries as efficiently as the disc-shaped normal red blood cells that we are looking at on the left-hand side. So if there is a folate or a B12 deficiency or an inadequacy is there, if they are adequate, the cells are going to divide normally, and you can see the normal RBCs. The size, shape, and color you can see, and these are mature RBCs, and they have lost their nuclei as well. Here you see if there is a folate or a B12 deficiency, the cells are unable to divide. So megaloblastic cells in the bone marrow arrested at an immature stage, and they still have their nuclei, and they are slightly larger than the normal red blood cells that you can see there. So megaloblastic macrocytic anemia is what we are looking as a manifestation of a folate deficiency. So some of the implications of this folate deficiency we will take a look at, which are more important and more serious, and some new research also that is emerging related to a folate deficiency is also what we will talk about. So one of the most common things that we talk about in reference to folate is its association with the neural tube defects. Now, all those of you who are from a medical or a science background will know what is a neural tube. That is an embryonic tissue that will help to form the brain and the spinal cord. And neural tube defect is either because of a malformation in the brain or the spinal cord, or both, that can happen during the embryonic development, and often it may result, depending on the severity, in either a lifelong disability or even in there is a risk of mortality as well. And two main types of neural tube defects we will study under the headings. One is the types of spina bifida that occur, and also we will take a look at some other anomalies that happen related to the brain. So the brain and the spinal cord develop from the neural tube, and defects in its orderly formation during the early weeks of pregnancy in the embryonic development may result in various central nervous system disorders as well as death. Now, when we talk of folate deficiency in a pregnant mother, we have to understand that the requirement for folate actually happens prior to conception, because if she has a good pre-pregnancy folate status, there is no reason for a risk of a neural tube defect to happen. Neural tube defect has been shown to be improved in mothers who had a good pre-pregnancy folate status, and also if they were taking anywhere between 250 to 400 micrograms of folate per day if they were taking throughout their reproductive years. So that ensures that at the time of conception, she has a good folate status. But if it's a planned pregnancy, we will advise them to start the folate supplement at least 1 month before conception, if not more. And the supplement should be continued throughout the first trimester of pregnancy. If she does, from the preconception time, it can help to prevent the neural tube defects. And there are a lot of good case series that tell us that it actually really helps. So all women of childbearing age who are capable of becoming pregnant should consume 0.25 to 0.4 milligrams, that is 250 to 400 micrograms of folic acid on a daily basis. And this is easily accomplished by eating the folate-rich foods. Enough and more sources of folate are available. But if certain food groups are entirely missing from somebody's diet, then a risk of deficiency may be high. Also, folate fortified foods can be consumed, or a multivitamin supplement can be given on a daily basis. Usually for pregnant mothers on confirmation The iron supplement that is given also contains folic acid. But if it's a pre-planned pregnancy, then individual folic acid supplements or a multivitamin supplement, depending on the mother's micronutrient status, can be recommended. But sadly, and we know this, it's more in the developing countries, but across the world, a lot of the times the pregnancies are not planned. And if at that time the mother is deficient in folic acid, the risk of a neural tube defect becomes high in that case. Now, like it says here, because half of the pregnancies each year are unplanned, and because neural tube defects occur early in development, before most women even realize that they are pregnant, because in the first 28 days, 4 to 6 weeks, we say the neural tube is going to form and close also. By the time the pregnancy is confirmed, this is a process that would be coming to an end already. And that is why it is important for us to understand that a pre-pregnancy folic acid status to be maintained is important. So the FSSAI and in India and the FDA, that is the Food and Drug Administration, have recommended and mandated that grain products be fortified to deliver folate. Now, I have used both the terms here because in India it is at a stage of recommendation, and in the US it is mandated that all grain products to be fortified in order to deliver the folate. So this will be ensuring that everybody will get an adequate amount of folate as a percentage daily value of the RDA on a regular basis they can get from the fortified cereal grains that they are consuming. I'll show you the recommendations that are there for India in a little bit. Now, what is heartening is that once the fortification has started, and also in populations that are consuming the fortified foods, it has helped to improve the folate status of women of childbearing age, and it has dramatically lowered the prevalence rate of the neural tube defects. Now, improved folate status in women can happen either because of fortification, or it can also happen because of the other regular foods that she is consuming. Now, the advantage of fortification is that when we are picking something like a cereal grain, we know it is a staple food. It is something that a person is going to have on a daily basis. And that is the first principle of fortification, that we pick a food vehicle that the population in need is going to consume on a regular basis. So all these women of childbearing age, when they start taking folate as a regular product, a fortified product in their daily diet, that is going to help to prevent that neural tube defect from happening. Now, we also have more research that tells us that folate taken before and during pregnancy may also prevent congenital heart diseases, birth defects such as cleft lip and cleft palate, and also other neurodevelopmental disorders such as autism. Now, this is something that is being studied a lot, the role of folate in managing autism and preventing the severity of the autism spectrum disorders is something that is a current area that is being studied by a lot of people. So such findings that we get from various research publications, they strengthen the recommendations for women to pay attention to their folate requirements and folate needs. Now, the RDA for folate during pregnancy increases up to 570 micrograms per day as per the ICMR RDA 2020. That is the new RDA that have been released. Those of you who are not aware of the new RDAs that are available and you don't have access to that, it's a free download. If you just type RDA 2020 by ICMR and NIN, you will get a free download in the form of 2 documents. One is a summary document. So if you're just interested in the basics, you can download that. But it also gives you access to the full document, which gives detailed information about not just folate, but all the new recommended RDAs that have been issued by the ICMR and NIN as recently as August, September 2020. So RBC formation requires folate, we know that. The body also uses folate to manufacture new cells and the genetic material. So all the more reason the requirement in pregnancy has to be higher. And the early weeks of pregnancy are critical, like we said, for the formation and closure of the neural tube that will later develop to form the brain and the spinal cord. And remember again, at the cost of repetition, by the time a woman suspects she's pregnant, usually that is around the 6th week of pregnancy, the embryo's neural tube has normally closed, because that will happen about at 4 to 6 weeks, the neural tube will close. So just to show you, that is an infographic of neural tube. You can see here at 21 days. So this is the embryonic tissue that we are talking of, that is going to form the brain and the spinal cord. So at 21 days, you can see both the ends are open, the anterior and the posterior ends, both the ends are open. At 22 days, you can see it closing already. And at 22 days, this gap should not be there. It should be completely closed. So if this neural tube closes successfully and completely, then we know that there will be no defect in that neural tube, which means here the brain formation will happen adequately, and this spinal cord is also going to happen properly. Now, if there is a gap, that is when we are worried about any kind of a neural tube defect and the severity of the neural tube defect and how it is going to affect the fetus as it is going to progress. So a neural tube defect occurs when the tube fails to close properly. If the neural tube fails to close properly and the brain development fails, a rare but a lethal defect known as anencephaly is going to occur. That is, a baby is born without a brain. All such infants will die shortly after birth, so the risk of mortality will be high. In a more common neural tube defect, the spinal cord and backbone do not develop normally. The result is spina bifida, and it has various forms, and I'll show you the different manifestations. In this, the membranes covering the spinal cord often protrude from the spine sac, and sometimes a portion of the spinal cord and the spinal fluid is also contained within the in the sac. Now, depending on the what all is going to protrude in that sac, whether the spinal cord is also going to be there, the spinal fluid is also going to be there, whether it will be a closed or an open NTD, the risks and the severity of the manifestations will depend on the manifestation. So this is what it looks like at 4 weeks. The neural tube is yet to close. You can see the gap here at the top here. And at 6 weeks, you can see the complete closure of the neural tube. So that is a normal, successful development of the neural tube that you are seeing. And like it says here, one of the reasons for that to happen successfully is adequate folate status of the mother at the time of conception. So if the anterior part of the neural tube does not close properly, it can lead to anencephaly. And if the posterior part of the neural tube does not close, it can lead to spina bifida. So in spina bifida, so that's what it is showing you here. That's the sac that can protrude because of the gap. And in that sac, we are going to look for the presence of the meninges, the spinal cord, and the spinal fluid, which is going to decide what would be the complications that the fetus is likely to suffer. And on the right-hand side here, you can see a normal spine. So these are the various types of neural tube defects that can be seen and that can be manifested. We'll start with the spina bifida. So the first here is the asymptomatic NTD, what we call as spina bifida occulta, or what we also call as hidden spina bifida. So this could just be a small protrusion. You may have sometimes seen people have a small protrusion at the base of the spine. You'll see a clump of hair, or it's a small growth that is protruding, or like a small tail that is protruding. I'm sure I'll have a picture to show you for that, but that is the most non-serious type. Usually there is no implication, there is no damage to the nerve, so the person will not have any problem. But the only thing is, it could be aesthetically, it may bother somebody. So as the child grows older, they can later go in for cosmetic surgery related to that. But it will not really cause any kind of a damage, or any kind of a bowel or a fecal control will not be lost in this case. Then you have other types of spina bifida. This is a closed spinal dystrophism. Here you can see there is a lipoma. So a lipomeningocele is something. I'll show you another picture later on. This could be also one manifestation. Another manifestation is in the form of a meningocele, wherein you can see the protrusion of the meninges. It is filled with the cerebrospinal fluid, but there is no protrusion of the spinal cord in this case. So this is a little more of a concern. And then the most serious type that we have is a myelomeningocele, in which you can see in the sac. Also, it's usually an open NTD, or an open spina bifida. You can see here the protrusion of both the cerebrospinal fluid as well as the a part of the spinal cord is also protruding into that sac. And you know that if somebody has even a small damage to the spinal cord, they can have serious nerve damage as well. So this is one of the most serious types of the spina bifida that you will observe. Then also you have the craniorhachis, whereas it's a completely open brain and a spinal cord, and needless to say, survival will not be there. This is an encephaly, open brain, and there's a lack of the skull vault you can see on top there. This is an encephalophile, where you can see the herniation of the meninges. So this is what you can observe here, and this is in anencephaly, wherein you can see the occipital skull and the spine defects will be there in the child. So these are some of the manifestations that you see in the types of neural tube defects. So this is the spina bifida occulta. Like I said, that you might see a small protrusion, hair growth, or a clump of hair that will be there. Sometimes it is not even, somebody may not even observe it, but it also, thankfully, it is one of the most common types. They may not even be aware till such time it is discovered as a part of some other investigation. But if it is a big hair clump or it is a big protrusion, then of course it will be visible. Then this is the meningocele. You can see the spinal fluid here. But the if we are talking about what will be the complications, there could be some damage and there could be some defect in the child, and it could lead to some problems as the child grows older, both in terms of the bladder control, also in terms of walking. It may affect the child. So some motor controls may be affected in a meningocele. But the most serious one is the myelomeningocele. This is the most serious type, and because there is a protrusion of the spinal cord, so a lot of manifestations lifelong is something that the child may suffer from as a result of that. Bowel control, urinary control, everything will suffer for that child. So in a meningocele, you can see the fluid-filled sac, but the neural tissue remains unaffected. So the complications are also less. This is spina bifida occulta. You can see a small protrusion here. If you see very carefully, here you can see a growth of extra growth of hair that is right at the base of the spine here, and some more visible ones. You can see a bigger protrusion here, and here you can see a structure like a tail there. You can see along with a clump of hair. So this is a manifestation, but a word of caution for pregnant mothers who maybe in one pregnancy have a child with even a spina bifida occulta, because it does get classified as a neural tube defect. In the next pregnancy, they have an increased risk of a reoccurrence. So 40 to 50 per thousand compared to only 2 per thousand for all births. And because of that, we increase the supplementation for a mother who is conceiving for a second time and has a previous history of a neural tube defect for herself or in her immediate family as well. And that helps to reduce the risk to a very large extent. That is a myelomeningocele. You can see the protruding nerves as well as the spinal fluid in the sac. And this is mostly an open NTD. So the risk for the damage is very, very high. You can see the bulging that has happened, and invariably it will lead to some amount of nerve damage, which could lead to paralysis. And also these children may be at risk of suffering from mental retardation as well. Another manifestation and impairment that you can see associated with spina bifida is hydrocephaly. And we generally say that if there is a myelomeningocele, there is also a risk of hydrocephaly to happen along with that. So that is an enlarged head caused by hydrocephaly, that is the accumulation of water in the brain cavity. This is another type that I was showing you earlier, the formation of a lipoma. This is the lipomeningocele. You can see a lipoma or a fatty tumor. If this is manifested, it is associated with bowel and bladder dysfunction. So a lipomeningocele or a meningocele may result in some damage, but the most serious damage will happen if a child has a myelomeningocele. In that case, the manifestations will be more severe. What is the extent of the problem? Do we really have to worry about neural tube defects in developing countries more as compared to the developed countries? So if we look at some recent data that helps us to describe the prevalence of the problem in developing countries, we have a scarcity of data. So if you try to look for data, you will not find large-scale studies. There are some systematic reviews available, and I'll show you some data related from there. But generally speaking, there is a repository that is supposed to be there, wherein all hospitals, nursing homes are supposed to give data related to the neural tube defects, but those repositories are not up to date. So whatever figures we have are from small scale studies, and most of these are hospital based studies. So if there are entities happening as a result of smaller nursing homes where you see, or in a home birth situation, or in the remote areas, or in rural areas where you have people not coming to the hospitals, then the data remains incomplete in that case. So because there are few public health interventions involving folate supplementation, it is likely that the prevalence rates mentioned in the previous studies would not have altered to a significant degree, because we don't have the entire data. Now, according to various epidemiological surveys that have been conducted across the country, the prevalence of NTDs was fairly high and varied in different parts of India as compared to across the world. So it's as low as 1.1 per 1,000 live births in Kolkata to as high as 18 per 1,000 live births in the state of Rajasthan. And another study showed that the prevalence of NTDs was 11.4 per 1,000 births in one of the areas of India's, and a study from China showing that in their northern provinces, the rates of NTDs range from 5 to 6 per 1,000 live births. And that is very high compared to the developed countries. Magnitude of the problem can also be judged from the prevalence rates in the US, which according to a survey were 1 per 1,000 live births. So like I said, the prevalence and incidence is there across the world. It's just that the developing countries have a higher incidence and prevalence rate. A report from WHO indicated that the percentage of women, pregnant women with serum folic acid levels less than 3 nanograms per ml was highest among pregnant women in Sri Lanka, followed by India, Myanmar, and Thailand. And another thing now they have started doing is they have started screening pregnant mothers with certain biochemical markers, like the maternal serum alpha fetoprotein levels are checked now in pregnant mothers where there is a suspicion that she could have a neural tube defect, or maybe she had a previous child with an NTD, or there is a history of neural tube defects in the family. So elevated levels of the maternal serum alpha fetoprotein levels is indicative that she may have a neural tube defect. So in that case, they can be advised, and then usually a 3D or a 4D scan will show if it is an open NTD, and this is something that will usually happen only if there is an open NTD. So the parents can take a call whether they want to go ahead for an abortion and for a medical termination of pregnancy. A few more studies that I would like to show you. One was a study carried out by NI in Hyderabad in 40 apparently normal men to examine the relationship between plasma total homocysteine level and folate and B6 status. So this is something I'll come to after this, is the relationship of folate with the risk of heart diseases. The mean plasma homocysteine level was high and was inversely related to folate status as judged by RBCs, or the plasma folate concentration. So when there is a deficiency of folic acid, it leads to an increase in the homocysteine levels and accumulation of homocysteine, which is not good. It is considered as one of the markers for cardiovascular disorders. The overall pooled birth prevalence, that is the random effect of neural tube defects in India, is 4.5 per 1,000 live births. This is according to a systematic review carried out by the Public Health Foundation of India. Their paper was titled Birth Prevalence of Neural Tube Defects and Orofacial Clefts in India. Again, not a small number, it's a high number. Another study that was done by the Banaras Hindu University in 2016. This is a population-based survey for neural tube defects births of rural areas in eastern Uttar Pradesh, and these districts are among the least developed among the other districts, and data shows an incidence of 7.48 per 1,000 live births. So we do have data coming in from the northern part of the country. This is a similar study in 2005. This is data from 2006 16. This is data from 2005, and you can see there is not much improvement. So the frequency of entities ranged from 3.9 to 8.8 per thousand live births, but the incidence in rural areas is unknown. One of the villages in Uttar Pradesh, that is one of the least developed regions in the country, the prevalence is between 6.5 to 8.2 per thousand live births, which is among the highest worldwide, not just in India. So one of the strategies that the government of India recommended, and it is in place and it is being practiced as well, is to give iron and folic acid supplements to pregnant mothers as a part of the National Anemia Control Prophylaxis Program. So all pregnant mothers are given 1 tablet per day containing 60 milligrams of elemental iron and 0.5 milligrams or 500 micrograms of folic acid. And this is something that is continuing even till now. But like I said, if pregnancies are planned, a single folic acid supplement of 500 micrograms is started 1 to 3 months prior to conception. If a folic acid status is not too bad, then even 1 month before conception, it can be started. But a good pre-pregnancy folate status will help to bring down these numbers, and other strategies were to start fortification of the food grains. So another concern that is there is the association of folate with the heart diseases. One of folate's key roles in the body is to break down the amino acid homocysteine. Without folate, homocysteine is going to accumulate, which seems to enhance the formation of blood clots and atherosclerotic lesions. And that is why it is a marker of cardiovascular disorders. So natural and fortified foods and folate supplements will help to raise the blood folate levels and reduce the levels of blood homocysteine. However, we must understand that every time reducing the level of blood homocysteine may not reduce the risk of heart attack, stroke, or death from cardiovascular causes, because there are other confounding risk factors as well. So reducing the blood homocysteine level is going to reduce the risk for that person, but it may not actually reduce the risk of mortality for an individual. So the decision to fortify the grain products with folate was strengthened by research suggesting a role for folate in protecting against heart diseases. But there are a lot of papers that have told that in people who have adequate folate status, for them generally blood homocysteine levels remain within normal limits. So compared to people who have higher blood homocysteine levels, the risk of any cardiovascular abnormality or an adverse event to happen will be lower for these individuals. Another area of research that is still ongoing is the association of folate with cancer. So we must understand that because the synthesis of DNA and the transfer of methyl groups depend on folate, its relationship with cancer is a little bit complex, depending on the type of cancer and the timing of the folate supplementation. Some research suggests that sufficient folate may protect against the initiation of cancer, whereas other studies report that higher intakes may actually enhance the progression once cancer has begun. Also, there is a contraindication between the anti-cancer drugs that a person may be taking and the folate supplement that we give. So it has to be really understood as to whether the folate supplementation in that particular type of cancer is going to be beneficial or not. In general, foods which contain folate probably reduce the risk of pancreatic cancer. We have sufficient low to moderate intensity evidence from research papers. Also, there is some limited evidence that suggests that folate may also reduce the risk of esophageal and colorectal cancers. But generally, we say that a good folate status for an individual will help to prevent some of the damage that can happen. Also, this is relevant with advanced ages. So as a person is advancing in age, this is something maintaining adequate folate status in that case also becomes important. So what are the recommendations that we have now, having understood what is its importance in daily life? What do we understand should be given as a daily dose for an individual? Now, when we recommend any nutrient, we also have to understand what percentage of what we are going to give is going to be utilized by the body. So the bioavailability and the actual utilization is also important. And in case of folate, it differs depending on the source. And these differences should be considered when we establish a folate recommendation. And we know that from plant sources. So while we say that some of the better sources of folate are among the plant kingdom, the presence of some inhibitors, especially insoluble fiber, and soluble fiber will inhibit the bioavailability. And keeping that in mind, the recommendations then have to be higher. When we know the bioavailability is hampered, we increase the recommendation so that resultantly the body gets minimum what it requires. Now, the naturally occurring folate from food, that is the polyglutamates that we said, they get full credits. And synthetic folate from fortified foods and supplements are given extra credit because on an average, it is 1.7 times more available than naturally occurring food folate. So this is what is available. Out of that, what is utilized is what we will come to next. So what it means is when we say that what is coming as synthetic folate from a fortified food or a supplement in a monoglutamate form, and we say that it is 1.7 times more available as compared to a naturally occurring folate. So a person consuming 100 micrograms of folate from food and 100 micrograms from a supplement, so we'll multiply that by 1.7 because it is 1.7 times more available. They are receiving 270 dietary folate equivalents. Now, how we arrive at that number? Usually we say that if a person is consuming a pure folate food, the availability may be as high as 85%, but in a mixed diet, we say it comes down to 40 to 50%. So keeping that in mind, if we say that a person receives adequate amount of dietary folate equivalents, and from there the body is able to absorb at least 50% or 60% of that, meeting the recommended daily allowance of folate through dietary, natural dietary sources is not a difficult thing to achieve. And the need for folate rises considerably during pregnancy and whenever the cells are multiplying. So recommendations for pregnant women are considerably higher as compared to that for other adults. Now, another thing that will interfere with the body's folate, one I told you, of course, is the anti-cancer drugs that can interfere with that. Then also aspirin and antacids will interfere with that. Aspirin inhibits the action of the folate-requiring enzymes, and antacids will limit the absorption of folate because it needs the acidic medium. So healthy adults who use these drugs to relieve an occasional headache or upset stomach need not be concerned. But people who rely heavily on aspirin or antacids should be aware of the nutrition consequences. So if you are taking once in a while, it is fine, but on a continuum, it will reduce the bioavailability of folate. Folate fortification, we said, is something good, but the safety concerns are also there related to that, because if we give very high amount of folate through a supplement that is coming from or it is coming from a fortified food, very high intake of folic acid can actually mask a vitamin B12 deficiency, and this will then delay the diagnosis of the neurological damage. So because of that, folate consumption should not exceed 1 milligram daily without close medical supervision. So 1000 micrograms or 1 milligram is what we say is an upper limit for an adult. We say is the tolerable upper limit for an adult. But in times when the mother has had a previous NTD in a earlier pregnancy, we do give her a higher dose, but like it says, she has to be in close medical supervision at that time. So RDA for normal adults is 220 to 300 micrograms, 220 for adult women and 300 for adult men, because they require more because of the lean mass accumulation being higher. Pregnancy, the RDA goes up to 570 micrograms per day. In lactation, it goes up to 330 micrograms per day. So anytime, whenever there is a phase of growth going on, the requirement will be higher. And you will realize that maximum recommendations that increase will be either during the period of pregnancy or during the first year of a child's life, that is during infancy. And within infancy, again, in the first 6 months of a child's life, the recommendations per kg body weight will be the highest during that time. And for children from 1 to 18 years, so for 1 to 3 year old children, it is about 110 micrograms per day. And as they reach the age of 18 years, that is adulthood, it stabilizes at about 220 to 223 micrograms per day. Again, something which is not at all difficult to achieve from the regular dietary sources that we consume on a daily basis. For children, we say that even 50 to 100 grams of green leafy vegetables, if you give them. Smaller children 50 grams, little bigger children 100 grams of green leafy vegetables cooked into a vegetable or a puree, or you can stuff it in certain other foods that you are giving them. That will really help to maintain that folate status. In addition, we have other good food sources as well. So in pregnancy, 570 micrograms or 0.57 milligrams for a regular pregnancy is what is recommended. So the government recommendation of the 500 micrograms was before this 2020 recommendations have come in, but that is something that probably may change. But if 500 micrograms comes from the supplement, the remaining can be easily met from other food sources of folate that we eat on a day-to-day basis. Among the plant foods, green leafy vegetables and all green vegetables, broccoli and all are very good sources. Then you have the citrus fruits, oranges, grapefruits, they are all very good sources of folate, also bananas. Then pulses and legumes are another good category of folate providers. They will give almost double the amount of folate that you will get from the cereal group. But also remember one more thing, that we consume cereals in much larger quantities as compared to the legumes. So overall, they will contribute quite a lot. Other things that will also contribute are potatoes. They're not very good sources, but starchy foods are again consumed in higher quantities, so that will contribute a lot. Also dairy. Not high amounts, but because if you consume 3 to 4 servings of milk and milk products, you will again get a good amount of folic acid from there as well. So for pregnant mothers, like I said earlier, we should start the supplement at least 1 to 3 months prior, or increase the intake of folate-rich foods. Generally, we give them in combination with iron, and we start immediately on pregnancy confirmation. That is in case the pregnancy was not planned, but if it is planned, we have to start it before that. Also, this is another important thing to remember. If the mother has a prior child affected by a neural tube defect, supplementation in the subsequent pregnancy should be increased 10 times. That is 4 to 5 milligrams per day, or 4,000 to 5,000 micrograms per day. Normally, we are telling to give about 500 to 570 micrograms per day for a regular pregnancy or a normal pregnancy. But in case a mother has had a previous problem, or an immediate family, that means in her sister or a very close relative, if there has been an NTD, her risk in that case is higher. And giving 10 times the RDA of folic acid during pregnancy for the subsequent pregnancy does cut down the risk to almost 80 to 90%. Risk is lower if you give that supplemental dose in a very high quantity. What is the amount of presence of folate in foods and their bioavailability? Foods that have the largest amount and of most bioavailable folate are liver, legumes. I showed you a picture, all pulses and legumes, and leafy green vegetables. Other rich sources are avocados, oranges, grapefruits, most citrus fruits. And like I said, milk and potatoes are not very good sources. That means quantitatively, they don't have a lot of folate, but because most people will consume them as a regular daily intake, it will contribute a lot of the daily RDA. Fortification of cereal grains and folic acid in India began only in 2016, whereas in developed countries, for example, in US, this is something mandatorily that started in the late 90s, 1998, if I'm not mistaken, or around that time. So from then, the prevalence of NTDs in USA has really come down. So if this happens, the products made from these cereal grains will also have a good amount of folic acid. The biological availability of naturally occurring folates on a mixed diet is anywhere between 50 to 80% of folic acid in fortified foods. So the studies for actual availability in India from the food folates is actually less, but this is some data that has been issued by the ICMR, wherein it says that over 70% of the folate from eggs, 60 to 70% of the folate from pulses, and from the green leafy vegetables, and 50% from other vegetables is actually absorbed, which is much, much better than the bioavailability of iron. For those of you who have studied and who know, bioavailability of iron is anywhere between just 5 to 10% from the total intake that we do. But in this case, you can see here, the bioavailability is also not that bad, and also there is a bigger variety to choose from. Several dietary factors like fiber will affect the availability of folate from the foods. But in Indian diets, in the mixed diets that we consume, it is assumed that 50% of the folate is absorbed. And keeping that in mind, the RDAs are fixed accordingly. Also remember, folate is a water-soluble vitamin. It is extremely susceptible to destruction by heat, oxidation, as well as UV light. Vitamin C in foods helps to protect folate from oxidative destruction. Good amount of folic acid that we consume, and if we consume adequate folate from the diet, also it reduces the risk of oxidative stress. Food processing and preparation can destroy 50 to 90% of the folate in food. And this is again from an NIN study, a detailed study that involved different Indian recipes, demonstrated that the average loss of folates during cooking itself is 32%. So if you have a food that contains folate and you are consuming, 32% loss may happen during cooking. Some more loss may happen in the process when you digest. Everything that you are going to consume is not going to be fully bioavailable. So at the end of it, that is why we said about 50% of it is actually absorbed and used by the body. Food sources, I hope by now if I ask, you should be able to tell me some food sources of vitamin B9 or folate. Fish is a good source. Both seawater fish as well as river water fish is a good source. Liver, pork liver, beef liver, all are good sources of folate, and also the bioavailability is high. Poultry is a good source. Then dark green leafy vegetables, like I said, darker the color, the better. The concentration is higher. So when you're taking it in a larger amount, and because of fiber, if the bioavailability is reduced, you still get a lot of folate that you are consuming. Whole grains and citrus fruits and juices like orange, grapefruit, lemon, all of them will also provide good amount of folic acid. So you can see all those foods listed here. In this case, we don't usually say that the bioavailability is only going to be higher from the animal foods. It's not like that. Plant foods also will give us good amount of folate. This is just to show you some of the Indian foods of regular consumption that give us good amount of folate. This is something I have taken from the IFCT, that is Indian Food Composition Tables 2017, released by ICMR and NIN. Again, this is something available as a free download from the internet. If you want to download the Indian Food Composition Tables 2017, that is a book that is from the NIN website. If you just type in the keywords, you will be able to download. If all the nutrition students who are here, and especially if our nutrition college alumni are there, they will already know that this is available as a download. So here you can see, starting with the liver, so beef, pork, sheep, goat liver, good concentration. So this is in 100 grams of edible portion. This is moat beans, that is the, the whole, just like you have the whole green gram, it looks something like that. This is usually sold. People from North India, if you've been, you'll understand this is something that is also sold as a chart sometimes. But just like how we have the whole green gram, this is also something like a moat bean. Good concentration, that's a legume. So again, you'll notice the legumes have a higher concentration compared to the pulses. So that's rajma. I'm sure you're familiar with the rajma. Soya bean, black-eyed peas. This is moat bean. The picture is not very clear for you to see. Then whole Bengal gram. Again, that is your Kabuli chana. Again, a good source. Then you have the green leafy vegetables, whether it is spinach, parsley, any green leafy vegetables, even our local greens that we consume on a daily basis, our drumstick leaves, curry leaves contain good amount of folic acid. Remember, folic acid, foliage, folium. So that is where the term comes from. black gram in the whole form. Then you have gingerly seeds, that is our white gingerly seeds. This again a very good source, and agati leaves. So any local grains are also good sources of folic acid. This is just to show you very quickly, and I'm coming towards the end of my talk now, the recommendation for fortification of the cereal grains in India. This is by the Food Safety and Standards Authority of India, that is FSSAI, regulations issued in 2016 for fortification of atta, that is whole wheat flour, and maida also, that is the refined wheat flour. And the recommendation per 100 grams is to add iron. Separately, they have specified for the atta and the maida and other products, and also the salt that should be used, and folic acid to the tune of 1,300 micrograms per 100 grams. So when we do it to that level, and you take into consideration the quantities that a person is going to have, enough and more folic acid will then be available through a fortified food. And as you can see here, it's not just for folic acid. The fortification recommendations are there for other micronutrients as well. And that's what I began by saying, that remember, we usually don't give a single micronutrient supplement. We usually give a food because natural foods also contain multiple nutrients together, and none of the foods give us only a single nutrient. So again, when we are going to fortify something and make it a complete food for somebody, we better make sure that we are giving other micronutrients as well. So that is wheat fortification, wheat flour fortification. But we know that a majority of the population across the world, or even in India, are not wheat consumers. You have a lot of rice consumers. So similarly, recommendations by the FSSAI have also been given for the fortification of rice. Same thing, 1,300 micrograms, and also for iron and other micronutrients. Now, the fortification in rice, you may ask, because in wheat flour, it's easy to put it in the form of a powder. Whereas when we do the fortification for rice, it can be, sometimes they spray on it also, but they also follow what we call as a extrusion method, in which they form kernels or grains which resemble rice, which are actually made from mashed powdered rice. And in that you have the multiple vitamin mineral powder, which also includes folic acid. And they are shaped like pellets or rice kernels. They are shaped like that. And then you decide the ratio in which it has to be added to the regular rice. So depending on the concentration of the micronutrients in those rice kernels, you can allow a combination of 1:100 or 10:100 in terms of grams. So 1 gram of the fortified rice kernels to 99 grams of regular rice. So when it is cooked, it is added at that time. One reason that is usually done is also to make sure that the availability is there, because when you add so many multiple nutrients together, there may be nutrient-nutrient interactions which will reduce the bioavailability in some cases. So in summary, 220 to 300 micrograms of RDA for adult men, women and men respectively. Functions: helps in the development of the RBCs, formation of new cells, formation of DNA, formation of neural tube in the fetus. Sources: green leafy vegetables, liver, legumes, certain fruits, milk, nuts, dairy products, and cereals. Deficiency can lead to megaloblastic or macrocytic anemia, slowed growth because of the interference with the cell regeneration. Spina bifida and other neural tube defects are common if folate deficiency occurs in pregnancy. In severe deficiency, there have been some reports of infertility and even sterility that can happen in certain cases. So those are the references. Mainly I've used 3 books. Also, I used the Indian food composition tables, which I forgot to add here, as one of the references. This is what I was telling you about, the RDA 2020, ICMR and NIN. It's a good book. It's a free download. So those of you who don't have it can still go ahead and download that. Thank you, Dr. Ajit. Thank you, all the interns and the CliWare Research Solutions team and all the participants, all the participants. I'm told by Dr. Ajit that we have a good audience today.
Yes, we have good number, and we have, I think, many questions also. Still, there are 65 people in YouTube and some 30 people here, ma'am.
Okay.
And I think they may watch later also, because it will be live and on YouTube channel. And
Okay.
more than 500 people registered actually. Maybe I think odd time because maybe they're coming from the work home. I mean, we can just
Okay.
expect anything.
Okay.
Yeah.
One second, I'm just
So,
trying to stop sharing.
okay, ma'am. Yeah.
Are you able to see my screen?
Yes, it's still. Shall I?
Stop share. Okay, I got it. Yes.
Yes. Okay. So, Kangan, hello.
Thank you so much, ma'am. It was quite illuminating and insightful for the topic. I hope my voice is audible, sir.
Yes,
Yes.
thank
Yes.
you, Kangan. I'm not sure if people are putting questions in the chat because I'm not able to see that.
Yes, there are questions. Kangan,
Ma'am,
you
there
please
are
take some
questions.
questions.
Yeah.
Yeah.
Ma'am, now I would request you that can you answer some of my questions from my fellow audience? I would
Yes,
like to
please.
start with a question that is put up by Shritija. That is, does folic acid mask vitamin B12 deficiency? If yes,
Yes,
how?
it does. And that is something I mentioned also. That is why when we are giving the recommendation for folic acid, we should not give it more than what is recommended. A lot of the times, people are taking over the counter. So when somebody gets a low hemoglobin report, they start taking on their own, because they know the hemopoietic nutrients include iron, folic acid, B12, and vitamin C. And if at all they come to know that they have nowadays, when you do a complete blood count, along with iron, because this is something that is a likelihood, B12 deficiency we know is something that is happening regularly, but now they are also checking for the folate status as well. So if somebody finds out that and they start taking a folate in a high dose, it will mask a B12 deficiency definitely. So we have to be very careful with that.
Thank you, ma'am. That was very keen. Moving on to the next question by Ruthwik. If the excess amount of unmetabolized folic acid gets accumulated in the body, does it lead to any serious consequences or harm to the body?
Can you please repeat, Kangan, one sec?
Yes, ma'am. If the excess amount of unmetabolized folic acid gets accumulated in the body, does it lead to any serious consequences or harm to the body?
Not that we know of, because if it's something of a concern when we talk of children, but in the adult population, when we talk of the tolerable limits that a person can have, it's actually quite high. Because if you look at the RDA, we are looking at something like 200 to 300. For men, we are looking at 300, and the tolerable upper limit is 1000. And that too also, when we say 1 milligram, actually, when studies have been done with even higher amounts, when people have taken in the form of supplements, it has really not caused actually, when we have a folate deficiency and then because of that the homocysteine levels go up, that is when we have a concern. But we have
Okay.
to see the tolerable upper limits. For children, they are not, the difference is not much. As much in adults, we say that up to 4 to 5 times it will not cause a problem. In children, 1.5 to 2 times also is something we have to take care of.
Thank you, ma'am. The next question is from Chaitanya. Is there any relation present between folic acid and acidity disorders?
Yes, that's what I said no earlier. When if somebody is taking antacids, in their case the absorption of folate will be hampered. The bioavailability will become lower in that case.
Next question is again from Rutvik that, ma'am, if there is a healthy woman, age of 49, whose hemoglobin levels are near normal levels, approx 9 milligram per deciliter, who is near to menopause. So can she start taking folic acid as a daily supplement?
I have to ask him as to why folic acid and hemoglobin of 9 is actually low. It's not near normal.
Yeah.
It should be close to 12 to 13.
Yeah.
So my question is, why a folic acid supplement? Does he have a case particular that he is wanting to ask about?
Rutvik.
Yes, ma'am. Good evening, ma'am. I'm Ritvik, ma'am.
Yeah, Ritvik, tell.
Ma'am, actually, one of my cousin,
Mhm.
her hemoglobin levels are approximately 9 mg per deciliter, ma'am. And she's
Okay.
around 49 years of age, suffering with a gastric acidity disorder, ma'am. So
Okay.
she was asking me whether she can take a folic acid supplement as a daily supplement.
Because of the acidity.
Yes, ma'am.
But what is the, because of her 9 mg of hemoglobin, has she been recommended any other supplements or medications?
Like she was taking magnesium oxide as a thing, ma'am, when she's suffering from the acidity disorder, and it gets released when she takes magnesium oxide.
If that is affecting her folate status, did she get a report also of her serum folate levels?
I didn't ask, ma'am, actually.
That is something you should ask, because if for acidity she is taking the antacid and that is probably affecting the absorption of folate, in that case, it's better to first get a serum folate level checked.
Okay, ma'am.
Because in a low hemoglobin level, it could be possible that she has a folic acid deficiency as well. But it is better to check directly for the serum folate level before thinking of a supplement.
Okay, ma'am. Thank you, ma'am.
No worries.
Now, the next question is from Dilna. What are the drugs that can cause folic acid deficiency, ma'am?
So, like I said, one is aspirin. Then you have the antacids. If consistently on a regular basis somebody is taking, and also we say that some of the painkillers can actually, not just aspirin, but other painkillers also can cause a folic acid problem with the bioavailability. And also, like I said, some of the anti-cancer medications will interfere.
Thank you so much, ma'am. It was an amazing experience to hear your incredibly interesting and informative session.
Actually, I have one question to ma'am, actually, from my side.
Go ahead, Dr. Ajit.
Yeah, being from the cardiology side, I will ask one question, ma'am.
Yes.
So, in many people, actually, in many, after delivery or fetus, they have congenital heart problems. Ma'am was talking about the, neurological disorders and others.
Yes.
So, does it really directly, associate with any congenital heart disease, folic deficiency, and yeah?
Like I said, we don't have a lot of evidence, but there are some papers that have talked of not just folic acid, they are talking as a combination. So they're talking of not one single micronutrient as being responsible. That is why they are not just saying that only folic acid is going to be responsible for that. So along with that, they are talking of a combination of three things they're specifically looking at is B12, folic acid, and vitamin B6 is what they're looking at together as a combination. And there are certain studies that have spoken about some congenital anomalies, heart diseases related to a deficiency in the mother and during the embryonic development time. But we do not have any specific evidence to say that it can be linked only to folic acid alone.
Okay. So how important it is to maintain the folic acids in during pregnancy, ma'am? According to
During
you?
pregnancy, it is important because the cell division is continuously happening.
Yeah, great.
So that's the reason, and also because the DNA synthesis and or the cell multiplication. So throughout the pregnancy, the mother will lead. In the beginning, the importance is more because of the formation and the closure of the neural tube. So that is an initial requirement. But throughout pregnancy, as soon as pregnancy is confirmed, that is something because the requirement during that time is going up to 570 micrograms. Now, it may not always be possible for her to get that much amount from her diet that she is consuming. Also, she has to look after her as well as the requirements of the fetus as well.
Okay. Yeah. Good, ma'am. So one more question. Actually, now it is quite different. So, any importance of folic acid supplements in patients after heart attack or after myocardial infarction?
See, again, it's a situation where they are talking of, like I said earlier, we cannot talk only of a folic acid supplement having any benefit or a thing for the patient post this thing. But they're saying that a good folate status does help, because it is going to, whatever said and done, it is going to help to maintain those homocysteine levels.
Yes.
For that reason. But otherwise, if we have to say that, will giving that folate prevent the next event from happening? Not sure, because there may be other risk factors that are not controlled.
Yeah, because as it is directly related to diabetes and diabetic ketoacidosis and all. Yeah.
Exactly.
So,
Because they're also talking of a big relation to the central body obesity as well.
yes. True,
Yeah.
ma'am.
Yes.
Yeah, that's from my side. Kangan, do you have any other question?
Yes, sir. The audience have still 2 more
No,
questions.
no worries. Ask 1 or 2 questions
Go
more
ahead.
is
Go ahead.
fine.
Yeah.
Yeah.
So now this question is from Alok Ranjan. The question is folic acid cytotoxic to human kidney cells?
There is some evidence, but I am not very sure if I have come across any paper. And to be very honest, I wasn't even looking for a paper related to that. But I do remember reading something about it. But I'm not sure. I'm sorry. I'll have to check if I have to. If you are looking for an evidence for me to tell, I am not sure.
And there's one more question from Chilukuru Sai. The question is, there are some antibiotics which inhibit the folic acid synthesis in bacteria. How is it going to affect the folate levels in pregnant women and normal individuals?
I'm confused with the question. So if we are talking of the antibiotic use by a person, so when a person is taking antibiotics, it will definitely affect the normal microbial flora. The gut flora will be affected at that time. So at that time, it is definitely going to affect the absorption and bioavailability of most of these nutrients, because it will disturb the pH as well. It will also disturb the gut flora. So it will affect the absorption and utilization of folic acid. In pregnant mothers, I didn't understand. Antibiotic in pregnant mothers?
No, I think these 2 questions are separate, ma'am. I think his 2 questions are separate. So, yeah.
So
Yeah,
I think for the antibiotic use, definitely it will affect the bioavailability because of the effect it will have. Because when we give an antibiotic, it is not only taking care of the disease bacteria, but also the normal healthy gut flora will be affected. And that is why nowadays, when most of the time you will see that when antibiotics are given, along with that, lactobacillus is something that is recommended. So that is something that will help in improving the status of the micronutrients utilization by the body. And in pregnant mothers, of course, like we said, the requirement of folic acid is definitely high. But I didn't understand that exact question during pregnancy, what they wanted to ask.
Okay, so again, there is a question from Dilna that are folic acid supplements safe to take during the entire pregnancy period, or should it be stopped after some time?
No, they are safe to take during the entire pregnancy. Like I said, during a regular pregnancy, when there is no previous history of an NTD in the mother herself or in a close relative, in that case, she can maintain that supplementation at about 500 to 600 micrograms per day, but not to cross 1 milligram during that time. However, if the mother has a previous history, then we increase the supplementation. We also say that we also have studies that have shown that in mothers who have twin pregnancies, we double the RDA for the mother at that time. Almost 1.5 to 2 times the RDA is what we give. From the pregnancy RDA, we increase it again to make sure that the requirements for the mother and the fetal development and the growth of the child are not affected in any way. So it is safe to consume throughout the period of pregnancy. Once the delivery happens and she goes into postpartum, that time we have to reduce the intake. We bring it down from 570, we bring it down to about 300 to 350 micrograms for the period of lactation. Again, she requires a higher dose than normal.
Yes, ma'am. The next question is from Amin Mohammed. What is the relationship of folic acid in depression or anxiety?
I'm not sure, darling. That's not an area I have looked at.
Okay, no problem. Yes.
The next question.
Yeah.
Sir, can I ask this?
Yeah,
Can be the
sure.
last question.
Sure. Go ahead, please.
Yeah. So this question is from Sanskar Viramani. The question is, does taking higher dosages of folic acid cause or worsen cognitive impairment among older adults with a vitamin B12 deficiency?
Again, when we talk of the cognitive impairment, are we talking of something that is identified, or are we talking of something that is perceived cognitive impairment is what we have to look at. But if somebody is already having a B12 deficiency, you are trying to ask, should we give a folic acid supplementation or not? Is that what you are trying to ask?
Yeah, actually, ma'am, he actually wants to know that if higher dosages are taken, do it worsen the cognitive impairment in older adults? That's it. It's that much is the
I'm not
question.
sure. I'm not sure.
Yeah. One more question is, can folic acid interact with other micronutrients also during
Yes,
pregnancy or supplements?
yes, it can. And but not like iron and calcium, but yes, it can compete with for the same absorption site. So usually we say not to take with calcium because in pregnancy the mother may be taking a calcium supplement as well. So we usually recommend that the calcium supplement should be taken at some other time during the day and folic acid at some other time during the day. And like I was telling you, when fortification is done, we usually try to do a fortification of folic acid and in an encapsulated form so that when the person consumes, there is a slow release, which means that the absorption of different nutrients happens at different times, which means they are not competing for the same sites, and actually the purpose for which you are giving, the utilization will really happen. So otherwise, nutrient interactions, vitamin mineral interaction, mineral interactions can also happen.
Yeah. Thank you, ma'am. The next question is, should children with autism continue taking folic acid supplements? Is asked by Manisha.
This is something, like I said, I am myself involved in one study where we are looking at the ASD and the folic acid supplementation. It really depends on the condition of the child and the severity that the child is having. But in small children, depending on the age of the child also, we will have to take a call on a case-to-case basis. So I cannot arbitrarily answer that question because it may then cause some problem. So if I know the case and we know the age of the child and the exact severity of the disease that a child is facing, accordingly, we will have to take a recommendation on a case-to-case basis.
Thank you, ma'am. Thank you so much, ma'am. It was an amazing experience to hear your incredibly interesting and informative session. I hope it was equally useful for the audience also. And thank you so much, ma'am, for your valuable time that you have given
Thank
us
you so
such
much,
a
Kangan,
nice
and
session.
thank you. My pleasure, and thank you, Dr. Ajit. And I'm sorry I kept pushing the date.
No, ma'am. It's fine. It's fine. Any day is fine, ma'am. Thank you very much for accepting our, invitation and delivering this lecture. I hope many of our students and many of our, academicians also who are in general public will get benefited by this. Definitely.
Thank you so much, and thank you all those who registered and listened to the talk.
Yes, ma'am. Thank you very much. Thank you.
Thank
Thank you,
you all
guys.
so
Thank you,
much.
everyone, for attending this talk. Thank you all.
Thank you. Bye-bye. Take care, and I'll
Bye-bye.
see you
Take care,
later,
ma'am.
Dr. Ajit.
Take care,
Bye-bye.
ma'am.